thanks to the organizers, especially my good friend Dr. Virmani and the Dr. A.N. Roy, Dr. Rajshekhar. So from diabetes, we are moving to a very close cousin of diabetes, coronary artery disease. And greetings from my hospital in Delhi. I have no conflict of interest. And the roadmap of today's talk will be, we'll discuss the diagnosis of non-ST elevation MI, biomarkers, then role of CT coronary angiogram, risk stratification, initial medical management, anticoagulants and antiplatelets, then invasive or conservative or CABG, and then take-home message. So I will be, my talk is based totally on the 2020 European Society of Cardiology guidelines, which are the latest and most comprehensive guidelines that we have got. So as you can see in this slide, the upper one part is you divide the presentation into three parts: low risk group, low probability group, intermediate probability group, and then you have the high risk, high probability group. The number one, the diagnostic help which you take is clinical important. The history, the clinical examination, and as you can see here, the low group is low probability group, which has an atypical chest pain. The ECG is normal. The troponin is not raised. So this is a group where you have to rule out MI. The whole purpose of triaging such patients is to establish two things: a high risk, very high risk non-ST-MI and ST elevation MI. Again, you can see the first two pictures. They are of low probability, so they don't need anything else. Probably they are non-cardiac, but still, if the risk factors are there, they can be subjected to further non-invasive testings. The intermediate group is two, where you can see that the presentation is more typical, the chest pain is more typical, the radiation is more typical, there are ECG changes, and the troponin is now going to rise. The role of troponin, especially the guidelines mention high sensitivity troponin, is extremely important in this, where you have to do at the time of presentation, which we call the 0 hour. Then you have to repeat it after 1 hour, and then after 2 and 3 hours. And that helps you in making a diagnosis either of NSTEMI, STMI, or you rule it out. So this is what you see here. There are ECG changes, and then the troponin is rising. The third group is where the ST changes are much more pronounced. The hemodynamic changes there. The patient is in a very high risk group, ST elevation or non-ST elevation. So this is again going into a very high risk group. So I'm just starting with a case. This is a case we did 3 days back. 46-year-old male presented with 14 hours of recurrent central chest pain relieved with sublingual nitrate. He's a diabetic smoker. ECG shows sinus tachycardia with ST depression 4 to 5 millimeters in vote B4 to V6. Saturation is okay. Blood pressure is okay. Heart rate is on the higher side. Troponin is this. We don't measure HS troponin yet in our hospital, so we measure TROP-I, which was 1.09. The transthoracic echo shows lateral wall hypokinesia, and this is the ECG which is shown here. You can see here that there is ST depression, quite significant ST depression from V3 to V6. We'll discuss what we should do in this case, and I'll tell you what we did. So the recommendation is a very important class 1 recommendation of the European Society of Cardiology, that the diagnosis has to be based on a combination of clinical history, symptoms, vital signs, other physical findings, ECG, and laboratory result, including high sensitivity troponin. It is also important to measure, as I told you already, that the time of admission, then you have to measure it at 60 minutes, then you have to measure it at 120 minutes, you have to measure it at 180 minutes. You must know that this is a lab test, which is not point of, it's not available at the bedside. So it takes about an hour. The turnover time is an hour. So when you are saying 0, that means you will get the result after 1 hour. It is also strongly recommended, again, a class 1 indication, that a 12-lead ECG should be taken within 10 minutes. And an additional leads, if you're not sure about the interpretation, like V3R, V4R, V7289 may be useful in ambiguous cases. So once you have suspected non-ST elevation MI, if you put that patient in very low category where you have seen that the high sensitivity troponin is not high, it doesn't rise after 1 hour, what we call the delta 1 hour, you rule out the evidence, diagnosis of non-STMI or STMI, patient can be discharged, and then you can subject that patient to other investigations later on. If it is an intermediate one, you always repeat the HSCT after 2 hours and 3 hours and see what is the rise. If the rise is substantial, you rule in an STMI or STMI depending on the ECG changes. You do the echocardiography, and this patient goes to the ward for angiography or stress testing or CT angiogram. If it's a very high initial HSCT and you see another very significant rise at 1 hour, you rule in non-ST elevation MI or ST elevation depending on the ECG changes. The patient goes to CCU and goes for a very early angiography. Echocardiography is only to see the LV function. So the value of high sensitivity cardiac troponin is emphasized again and again in these guidelines. And as you can see here on the left-hand side is the conventional assay where you see that almost 50% of the patients are missed. Whereas if you subject that person to a high sensitivity assay, you will find that almost 80% of the patients are detected. It has a very high negative predictive value for diagnosis of acute MI. If it is negative at the beginning, doesn't rise, you can almost rule out. What is the role of coronary CT coronary angiogram? In the recent time, it has become one of the most important tool in ruling out significant coronary artery disease. Has almost 100% negative predictive value. If the CT coronary angiogram is normal, you can rule out that this cannot be a significant coronary artery disease, except in certain cases where if HSCT is high, where we call it that, you could be type 2 myocardial infarction, MINOCA, and other things that we are not discussing at the moment. Now, the CT coronary angiograms are also, they have facilities of CT FFR and CT perfusion imaging, which leads to functional assessment in doubtful cases. So these patients, if they have significant FFR and perfusion deficit, they can be taken straight to invasive angiography. CT coronary angiogram also tells you about the plaque morphology, which is very important in prognosticating the patient as well as the management that you're doing. It is very cost effective. In fact, this is a slide I'm going to show you. In UK, the NHS is employing it as one of the first test to diagnose coronary artery disease presentation as NSTEMI. And as you can see here, cost effectiveness is very, very high, almost 90% if you compare it with the blue dot, which is the invasive coronary angiogram. The yellow dot is CTCA, which costs in UK is about 150 to 200 pounds, whereas if you see the invasive coronary angiogram and all other modalities cost more than 1,500 pounds. So they have decided that this should be employed in as many patients as possible. In all district hospitals now have facilities for this. Next, we go to the risk stratification, and associated with risk stratification is whether a patient requires an early invasive or delayed invasive investigation. So risk stratification is now done into 3 groups: very high risk group, and low risk group. Very high risk group, as you can see, are hemodynamically unstable, cardiogenic shock, recurrent refractory chest pain despite medical treatment, life-threatening arrhythmias, mechanical complication, acute heart failure, and ST depression more than 1 milliliter in 6 leads, or ST elevation in AVR and V1. High-risk patients are established where you have established the diagnosis. There are dynamic changes of ST. The patient has been resuscitated after cardiac arrest, but there are no ST segment elevation, or there is no cardiogenic shock, or the Grace risk score is more than 150. And you can see here at the bottom is the investigation which you have to follow. Now, this group is actually now being treated as ST elevation MI and needs an immediate invasive angiogram less than 2 hours. High risk group can wait. You can start your treatment and they should undergo angiography within 24 hours. Low risk, you don't need to do anything. You have to do non-invasive stress testing and other things to find out whether there is a significant coronary artery disease or not. This is again a group where if you still feel that you have a very high suspicion of ACS, there are a lot of risk factors. this is a group where CT coronary angiogram has a very important role to play. Now the risk scoring, the two most popular, there are at least 8 to 10. TIMI, thrombolysis and myocardial infarction risk scoring, and then there is GRACE 2. Europe mostly follows the GRACE 2 score, which is based on age, ECG, systolic blood pressure, creatinine, troponin, heart rate, cardiac arrest, history of cardiac arrest, and Philip class at the time of presentation. Any risk above 140 is taken as a very high risk. And as you can see here in this slide, that patients who were in high risk group and had a very high GRACE score more than 140, and early invasive treatment definitely help in reducing the hazard ratio. So this is something which we have to do. Unfortunately, we do not have any risk scoring, which has been validated on the Indian patients. So, for the time being, I think we have to use this only. This will be very useful. The initial medical therapy is oxygen, nitroglycerin, oral beta blockers, high intensity statin, antiplatelets therapy, anticoagulation therapy. Avoid routine transfusion is hemoglobin is more than 8, potassium has to be more than 4, magnesium more than 2. A non-invasive imaging is always a part of initial medical management. Now let's come to the antithrombotics in non-ST elevation. You can see that on the top are anticoagulant drugs, and at the bottom are the antiplatelet drugs. There is a host of them are available right now. The IV drugs which are available are bivalirudine, unfractionated heparin, and then you have low molecular weight heparin and fondaparinux. Then you have the oral drugs, apixaban, and the newer oral anticoagulants or direct oral anticoagulants, and the older one, BK. The antiplatelets that are available are the clopidogrel, prasugrel, ticagrelor, and the newer IV cangrelor. The IV antiplatelets are available, but they are not very much used except tirofiban, which is more frequently used than it was used in the past. So it's very important to assess the bleeding risk of all these patients. And I'm not going to go into the detail of this because there is I'll just tell you, there is a app now available, which is called an AARC HBR trade-off app, which is available on both, the iPhone platform as well as the Android platform. This is a very useful tool for people who are managing such patients. You can evaluate it very well. You will immediately know the risk score of that patient as far as bleeding or thrombotic risk is concerned, and then you will be able to tailor the antiplatelets and anticoagulants based on this. I'm not going into detail of that. If you want, I can do that, but this is an app which is easily available. You just have to feed in the patient data. It gives you all the information which you need. So as I was telling you, the antithrombotic and antiplatelet therapy has to think of two factors. One is the bleeding risk on one hand, and the other is the ischemic risk at the one hand. So patient characteristics, clinical presentation, comorbidities, co-medication, and procedural aspects are all taken into account to decide whether the ischemic risk is high or the bleeding risk is high. So you have to strike a balance between the two. And that is one of the most important things which you need to do, because you have much worse patients these days, older patients with a lot of comorbidities. Normally we are treating a lot of patients who are in their 80s or 90s, with a lot of comorbidities. So you have to think of both bleeding and ischemic risk when you are doing the. So the algorithm, again, this is something which, if you are in managing patients who have undergone angioplasty, then this chart is very important, which will give you the bleeding risk. As you can see here, that if the bleeding risk is low, these patients will require antiplatelet therapy for a longer period of time, maybe even more than 12 months of time, but minimum 12 months of time if there is a low bleeding risk. If it's a high bleeding risk, then you have to give dual antiplatelet for at least 3 months, then single antiplatelet for 12 months or more than that. If it's a very, very high risk, then in that case, dual antiplatelet therapy for 1 month, and then you have to switch to clopidogrel. Now, there is a definite movement against aspirin in patients who are having coronary artery disease, because it has been found that aspirin definitely increases the long-term bleeding risk, whereas the bleeding risk with clopidogrel has been found to be less. So more and more of patients are now being treated with single antiplatelet agent as in the form of clopidogrel. Again, as was the bleeding risk, we have to consider the thrombotic risk at the same time, and we divide our patients into two types: high thrombotic risk or moderately increased thrombotic risk. Now, this will again guide us the duration of and the intensity of the antithrombotic therapy, both antiplatelets and anticoagulants that we need to give. So a complex coronary artery disease with at least one of the risk enhancer, or a non-complex coronary artery disease with one of the risk enhancer, will categorize your patient either into a high thrombotic risk or a very moderately increased thrombotic risk. So again, there are a lot of factors. There are clinical factors, there are technical aspects, the number of stents you implanted, the number of lesions you treated, the length of stent you have done, the kind of complex treatment like left main or bifurcation you have done. So this will actually put your patient in a high thrombotic risk or increased thrombotic risk, moderately increased thrombotic risk, which will help you in actually tailoring the antiplatelet and anticoagulant therapy in these patients. So, we come across these patients with high bleeding risk almost every day. And so what are the steps you take to reduce that? These are the recommendations. You use the anticoagulation dose adjusted to body weight and renal function, especially in women and elderly patients. Radial approach as a default vascular access is again a very important thing. Proton pump inhibitors in patients who are above 65 years, who are history of dyspepsia, gastroesophageal reflux disease, Helicobacter pylori infection, or chronic alcohol abuse should be a routine therapy. Again, patients who are already on anticoagulation, there are certain guidelines that if the patient is on NOAC, don't stop that, continue that. And patients who have a INR which is more than 2.5, don't use heparin when you're doing the PCI. Patients who are on NOAC, whatever is the time of last administration, they must be given UFH, but at a lower dose. This is again what pre-treatment is not recommended in patients who are high risk of bleeding, and GP2B3A is also not required unless until it is needed for a bailout. So again, another group which is very frequently encountered these days is patients who present to you with atrial fibrillation. Now, these patients have, as you can see, that they require an anticoagulation almost lifelong, and then they develop coronary artery disease. They're undergoing PCI. They again should be divided into what is a default strategy, where if the bleeding risk is not high, thrombotic risk is also not very high, then you have to give triple therapy, one anticoagulant plus two antiplatelets, where the antiplatelet P2Y12 receptor inhibitor preferred is clopidogrel, and this should be used for one week, and then dual therapy for 12 months, and then only anticoagulation should be used. But if it's a high bleeding risk, you only give 1 week of triple, then double therapy for 4 to 6 months, and then single anticoagulation after 6 months. If it's a very high risk patient of ischemia or thrombosis, then you give triple therapy for minimal duration of 1 month, then you switch to double therapy for 1 year total, and then only anticoagulation. Early versus delayed invasive in non-STMI, whether NSTEMI is equivalent to STMI, as I've already, that very high risk group is to be treated as STMI, and everything has to be done. Now, this is, I'm just going to tell you yes. So this is, we have already discussed this. As you can see here, that very high risk group has to be treated like STMI, and they should be subjected immediately to the invasive angiogram, and then the treatment has to be decided based on the outcome of that angiogram. High risk group can be treated at a slightly delayed, but this is what we call an early invasive, less than 24 hours. Low risk, as I told you, might require a coronary CT angiogram if there are a lot of risk factors. Otherwise, they can go for, further testing, ischemia is there or not, and then they can undergo investigation as per that. So there are some special categories. Diabetes, I don't need to discuss diabetes in this forum. There are pundits all around. So, but I will just tell you that these days we are investigating for diabetes. Everybody who comes to our hospital, whether he presents as STMI or non-ST elevation MI, everybody has to be investigated for diabetes and treated accordingly. It is very important that hypoglycemia must be avoided at all cost, and you should start treatment only when the blood sugar level in your hospital is more than 180. And again, multifactorial approach and less stringent glucose control should be considered, as you are all aware of. I don't need to tell you anything. So chronic management, again, lifestyle changes are very important. And again, a multidisciplinary approach to with psychologists, with the physiotherapists, with the cardiologist. Everybody needs to be involved in that, and these are all class 1 recommendations. Influenza vaccine is again very important in these patients, and it should be offered to almost everyone. Statins, a word about statins. This is something which is most of the time is overlooked. Patient has just given a drug combination of ecosprin with statin of atorvastatin 20 milligram, rosuvastatin 10 milligram. It's much more important now to have a much more focused, on the level of LDL-C which we must achieve, which is recommendation is that it should be it must be reduced more than 50% from baseline, and the final LDL-C should be achieved less than 55 milligram in these patients of NSTEMI. You must check it after 4 to 6 weeks to see whether you have achieved it or not. If it has not been achieved, add ezetimibe. Again, wait for 4 to 6 weeks, not achieved. Now you have to go to PCSK9 inhibitor. So it's very important. Statin is one of the most important drugs. Other drugs like antiplatelets, antithrombotics, antihypertensives have to be used as per the requirement. Okay, so the take-home message for this is that NSTEMI has a poor prognosis, of course, depending on many clinical variables, the number of vessels involved, the clinical syndrome associated risk factors, then what is the ejection fraction of the left ventricle. So all these will determine prognosis, but it is definitely much worse than so-called unstable angina, which is not biomarker positive. So this is very important to differentiate between the two, because the prognosis is definitely poor. Early clinical diagnosis is possible with history, clinical examination, biomarkers, and CT coronary angiogram or coronary angiogram. The risk stratification helps in planning of the management. Antithrombotics, early invasive management in very high risk group definitely saves life. Lifestyle management, drugs to control risk factors are important for chronic management. Thank you very much for your kind attention.
Thank you, Dr. Pramod, for very comprehensive talk on non-ST elevation MI. You have given a very comprehensive idea. Just out of the, I want to ask one question out of this, away from this context. At present, we are using a lot of anticoagulant, particularly because of the COVID situations. Both, low molecular heparin as well as other oral anticoagulants. Can you guide us how long this low molecular heparin should be continued in such patients, or when they should be, other pain, non-ST elevation MI also, when they should be shifted to oral anticoagulant?
Let me make it,
Apexaban and all.
Let me give you a very quick reply. There is absolutely no indication to continue these anticoagulants after the patient has been discharged from the hospital, except in situations where it was started as a therapeutic management in patients who has had evidence of thrombosis, either DVT, pulmonary embolism, or any other systemic thrombosis. There are no guidelines which advocate that this should be used post-discharge. Absolutely none of the guidelines advocate it. I see it almost every day, patients who come with a D-dimer report, he's on apixaban. It is not recommended at the moment. Absolutely no reason to continue it.
Thank you very much. Thank you very much. Thank you for your excellent talk. I must congratulate you for this. And let us give a big hand to Dr. Pramod for an excellent presentation. The next